Thanks to LRF again for letting me speak on this topic. It's a very kind of fun topic to talk about, and hopefully we can answer some questions that you all may have. And yeah, like said, please put the questions in the Q&A, and I will do my best to keep an eye on it. But I may end up talking most of them at the end, reviewing them at the end. Okay. Let's get started. So these are my disclosures. I've done some consulting work and received some grants, including from LRF. I've also done some research, do have some research support from some industry sponsors, and some of these are with drugs that I'll be mentioning today. And I will be discussing a little bit of non-FDA approved treatments and off-label treatments, but not a whole lot with this particular talk. So our outline today, give a brief introduction to oral therapies in both CLL and non-Hodgkin's lymphoma, and then we'll discuss a few of the more specific types of oral therapies, including BTK inhibitors, anti-apoptosis inhibitors, which is really only one, the PI3 kinase inhibitor class, which has made a lot of changes in the last year, Lenalidomide, and then some other therapies, different class of therapies that kind of work more on the genetics of the cancer as opposed to the other ones which inhibit certain proteins. I will not be discussing specific issues with each specific disease-specific topics, excuse me. There are specific disease topics through the conference that I'll point you to. All right, some introduction. So actually oral therapies for lymphoma have been available for years. Several IV chemotherapy drugs can be given as oral drugs, including cyclophosphamide, etoposide. We generally stick with IV administration just for convenience. Most patients are already getting some form of IV therapy. So just staying in the infusion center, not having to worry about the difference in the oral therapies makes sense. And then there's some oral therapies that we've been using for a while that have fallen out of favor, but still work somewhat. So chlorambucil is a tried and true drug for CLL. We don't use it very much anymore, given the other more oral therapies that have come out that are clearly better than chlorambucil. As well as methotrexate, which is an oral therapy that we use for cutaneous T-cell lymphomas, as well as some other types of lymphomas. And also remember that prednisone is an oral therapy, and we use that often for lymphoma. These are not the main topics of the talk today. I just bring this up because we do have some history of using oral therapies, even multiple years in the past. So there's some differences in administration, of course. Well, one is and how these drugs are pros and cons of each one. So with the IV formulation, insurance covers for the most part both the administration and the drug itself. There's usually some small co-pays. For oral therapies, insurance does tend to cover most of them that are FDA approved, but co-pays are through a different part of the insurance. So usually Medicare Part B or your prescription drug coverage would cover oral therapies, whereas the IV therapies tend to come under different parts of the insurance. So if you do have prescription drug co-pays, and those are 20%, these are expensive drugs, so that can, again, become quite expensive. From a physician perspective, the doctor is really certain that the IV administration is getting to the patient, whereas with the oral therapies, it's uncertain. So let's say patient forgot to bring their pills on a vacation or got sick immediately after taking the medicine. I don't know if that medicine has been administered or not. And sometimes skipping a dose isn't a huge deal, but sometimes it changes how we think of the disease itself. With IV administrations, the patient has to come to the cancer center, whereas with oral administrations, they can be taken at home. So there's convenience to oral therapies versus IV therapies. With IV therapies, there's usually a pretty predictable onset of symptoms, whereas with oral therapies that tend to be more chronic, tend to be more, once we start them, we don't tend to stop them. The onset of symptoms can be a little bit less predictable, and sometimes they can be delayed. You can think that you're tolerating a therapy quite well for a while, and then some of these other symptoms start to develop. Why that happens, we're not 100% sure. We're used to managing all of these aspects fairly well. So all these things are topics that we can get through, but still something that we watch closely. So the first type of oral therapy that we're going to talk about is BTK inhibitors. And this is really the class that has changed the landscape of lymphoma therapy in the past 10 years, I would say. So BTK inhibitors are a class of medicines that don't necessarily kill the cancer cell itself, but really stun its growth. And what I'm showing here is a cascade of signaling. So how cancer cells are told to stay alive is mostly through extracellular, or the cancer cell needs something outside in the environment to keep it alive. BTK is a protein that's part of this cascade that helps to stimulate the cells. Think of it like an external stimulus, or caffeine, if you will. If you don't have the caffeine, the cancer cells can't really stay alive. And if outside, this is outside the cell, and this is inside the cell, and if you keep signaling through this pathway, which a lot of lymphomas are very addicted to this pathway. If you keep signaling, you continue to make more and more cancer, because it stimulates more and more genetic changes that then, or genetic division and cell division. But if you inhibit this pathway by taking out one of these proteins, then the cancer cell no longer has the caffeine, no longer has the food to continue to grow, and therefore it kind of stuns itself and then ultimately ends up dying on its own. So these cancer cells, BTK inhibitors don't necessarily kill the cancer, they stun its growth and it dies on its own. That's BTK there. We've known for a while that BTK is an essential protein in B cell development. We actually know that you can live without this protein, because there is a genetic syndrome where some patients are born without the BTK, and they are alive and can survive, but they don't make antibodies or your memory immunity, which is something that we've all been very familiar with the vaccines, particularly around COVID timeframe. And like I said, some of these B-cell non-Hodgkin's lymphomas are addicted to BTK activation. Stopping it is a very effective and very helpful strategy. Currently, there are 3 FDA-approved BTK inhibitors: ibrutinib, acalabrutinib, and zanubrutinib, but there are many others in development. And we'll talk about some of those, another kind of class within a class of BTK inhibitors after we talk about these 3. And this is the development of BTK inhibitors. It really has been remarkable that it's a fairly rapid development of ibrutinib, which was the first BTK inhibitor that was marketed and made it to the market, and then acalabrutinib and zanubrutinib. So very quick accelerated approvals, with full approvals coming shortly thereafter in multiple different disease teams. And this all has happened within, and this is actually an old slide, it stops at 2020. So all this happened within 8 years. This table kind of goes through the differences of these 3 drugs. So ibrutinib being the first in class, and acalabrutinib and zanubrutinib being the second generation. So ibrutinib is a daily dose. It's dosed at 420 milligrams for most types of approved indications, but for mantle cell lymphoma, the approved dose is 560 milligrams. It's a tablet, and it is specific from a dose based on the disease. So it's FDA approved for CLL, mantle cell, Waldenstrom's macroglobulinemia, marginal zone lymphoma, as well as chronic graft versus host disease. Acalabrutinib, again, a second generation BTK inhibitor, is given as a twice daily dosing at 100 milligrams, and is now in both capsules and tablets. Originally, the capsules prevented folks from taking acid-suppressing drugs like proton pump inhibitors, or most acid-suppressing drugs for stomach acid. That's a very common thing that happens in the American population, at least, acid reflux. So folks taking capsules of acalabrutinib and a proton pump inhibitor were not actually getting the absorption. The company has changed the formulation to tablets, which then allow you to take it with these acid suppressor drugs, and is probably going to phase out the capsules over time. Acalabrutinib is FDA approved for both CLL and mantle cell lymphoma. Zanubrutinib is another second generation BTK inhibitor. Both acalabrutinib and zanubrutinib are very similar, to be honest with you. There's little difference in toxicity, little difference in efficacy. This zanubrutinib is given twice daily at a dose of 160 milligrams, or you can take it once a day at 320 milligrams. These are capsules at 80 milligrams. So if you take 2 capsules a day, or 4 capsules, 2 capsules twice a day, or 4 capsules once a day. Slightly different approval situation. So it is not currently approved for CLL, although a lot of frontline studies have been done with zanubrutinib, just awaiting FDA review. But it is fully approved for mantle cell lymphoma, Waldenstrom macroglobulinemia, as well as mantle cell lymphoma. And like I said, these drugs don't really kill the cancer cells, but they prevent the signal, and then the cells die. This does mean that we end up getting few CRs. We don't get complete remissions, and that's really not our goal. Our goal with these drugs is really to control the cancer, make it decrease symptoms, but not necessarily to get really, really deep remissions. And we can keep, that also means that this class of drugs probably isn't best to stop. So we think that it's best to continue these drugs for as long as possible, as long as it's being tolerated and the disease the cancer is being controlled. Because again, we don't get that deep remission. We get these long-term stability of disease. And we've had some patients on ibrutinib for over 10 years now. It's not the usual. I think that's kind of an exception, but some ibrutinib's only been out for a little over 10 years, and some patients have been on it for that long. Some differences with these drugs are based on how specific they are to targeting BTK. So this is a map of all the proteins that are kinases, or work in the same, or signaling in the same manner that are in the cancer cells. And you can tell that acalabrutinib is probably the more specific BTK inhibitor. It hits BTK, which is this dark dot here. Ibrutinib, a little bit more dirty, if you will. It hits other kinases, and sometimes that's helpful and sometimes it's not. In general, we think the more selective the BTK inhibitor is, the more likely it is to have less toxicity and just hit only the target that you want. But sometimes from a resistance mechanism, it makes sense to have it to be a bit more dirty. So you're getting a bit more of you're not targeting just one thing, you're targeting multiple things. And in a drug that isn't really killing the cancer cells, then the more you target, the more likely you are to kind of stunt the growth. Zanubrutinib is somewhere in between ibrutinib and acalabrutinib for the amount of inhibition. And this is this is zanubrutinib by itself, but it does get metabolized to something more specific, which then is even more specific for BTK. So this isn't the full story with zanubrutinib. This is a comparison of the adverse events on these drugs. So, and with red being incidence or occurs in over 40% of the patients, white being under 10%, and all the gradients in between. This is all grades, so like simple things that we notice on clinical studies, and then grade 3 or higher events. And this is based on clinical study reports and not real world data. So some of the things that are pretty common with all of them are infection. The other real common thing is neutropenia. For some reason, it seems to be a little higher with the zanubrutinib dosing. Diarrhea seems to be a little bit worse with ibrutinib. And bleeding and bruising is clearly higher with ibrutinib, and we've got clinical studies to support that. The other thing that is not on here, it's over here, is atrial fibrillation, which is a common thing that we see with ibrutinib. So irregular heartbeats. And muscle cramps is also arthralgias, which is where that kind of comes in at. Usually low grade, but can happen also. These, as an on-class effect, so what you would expect, these cells or these drugs do inhibit both the cancer cell and normal immune function. So we do tend to see more infections with these class. I think it's kind of hard to say that one's any better than the other, particularly with pneumonias, upper respiratory infections. Sometimes this is based on how they're coded in the EDC. So this is kind of a summary of the differences, and we may kind of pick and choose based on some known issues. Like someone with atrial fibrillation, I'm not likely to give ibrutinib to, or someone who needs to be on blood thinners or has easy bruising or bleeding, I'm probably not going to use ibrutinib. But someone who has headaches, which is a common side effect with acalabrutinib specifically, I'm probably not going to use acalabrutinib for someone who has regular migraines or something of that nature. I'm probably going to choose either zanubrutinib or ibrutinib. So yeah. And again, I kind of spoke a little bit about atrial fibrillation. I didn't speak about hypertension, but there's been two studies, the Elevate and Alpine, in different patient populations. So high-RAS CLL and Waldenstrom's macroglobulinemia, that compared acalabrutinib to ibrutinib and zanubrutinib to ibrutinib. There's not really been a study to compare acalabrutinib to zanubrutinib. I don't really know that study is really needed, to be honest with you. But this is the CLL study, the Elevate study, looking at acalabrutinib, and this is incidence of atrial fibrillation. So the more patients, each time a patient would get atrial fibrillation, this curve would go up. So the higher part of the curve, the more likely it is to have atrial fibrillation. You can see that more patients that got ibrutinib had atrial fibrillation than did acalabrutinib. Same with hypertension, which actually tends to be a later effect of ibrutinib, but patients who have high blood pressure are more likely to, well, actually anybody starting ibrutinib is more likely to experience high blood pressure than they are with acalabrutinib. So many of us, because of these two studies, and by the way, the findings were very similar with zanubrutinib, with atrial fibrillation, hypertension, as well as serious bleeding. And that's probably because some of the off-target effects of ibrutinib. Most of us are now not using as much ibrutinib as we were in the past because of the other two are safer, at least based on these two studies, but also equally effective. So we know that there's no difference in efficacy in these two studies that evaluate how well acalabrutinib or zanubrutinib worked against ibrutinib in these two disease settings, and there was no difference. So generally, we think that the second generation BTK inhibitors are a little bit more safe than the first generation ibrutinib, but also equally effective. I will say, though, patients who are on chronic ibrutinib and are tolerating it just fine, there's really no reason to switch to one of the second generations because not everybody gets atrial fibrillation, as this curve shows, only a little over 20% at 5 years. And same here with hypertension, about 35% at about 5 years. So it's certainly not a reason to switch somebody from ibrutinib to acalabrutinib. Although someone who has an adverse event on ibrutinib may make sense to either hold the drug and wait to the disease to may do something, or to switch to acalabrutinib or zanubrutinib. So in summary, for the BTK inhibitors, they're highly active in many different B-cell malignancies. They limit the cancer growth, but don't actually kill the cancer cell itself, or at least they have a minimal amount of that. Thus, we think partial response is actually very reasonable, and disease control is really our goal and is typically found. We also don't think that they really should be stopped. The newer generation BTK inhibitors are safer than the first generation, But again, if you're tolerating ibrutinib, we wouldn't switch. Sometimes we will add rituximab to these if we need a quicker response or a deeper response. Sometimes we can do a monoclonal CD20, rituximab, or even obinutuzumab. And the choice of the BTK inhibitors depends on many patient-related factors. And I will say, and I'll spend a little bit of time on this, there are some newer generation and second generation, other than the second generation BTK inhibitors in development that actually inhibit BTK in a different manner. So these are what I call the up and coming BTK inhibitors, and they're called non-covalent BTK inhibitors. None of them are approved yet. There's a couple that are pretty far along. And these drugs, the reason I'm bringing them up now, are probably going to come to market soon. But the covalent BTK inhibitors, which are all the ones that I talked about more specifically, ibrutinib, acalabrutinib, zanubrutinib, all stop BTK in the same manner, meaning that they lock on to the protein BTK in the same spot, the same manner, and inhibit it in the same manner. And they do so in a covalent manner, meaning once it binds on, it's stuck, it's glued to it, and it can't be unglued. The molecule, the inhibitor, can't be unglued and then go attach something else. It's stuck, and thus this puts a lot of pressure on BTK and ultimately some genetic pressure that then it's very easy for the cancer cells to just genetically change the pocket around a little bit, so you no longer have the ability to attach or glue this one target. The non-covalent BTK inhibitors, these ones that are coming to the market soon, stop BTK in a different manner and in a different area of the pocket, and can come on and off the protein. So they're not glued. So they can bind and then go bind another one and then bind another one for a little bit, inhibit its growth, slow it down, go bind another one, inhibit its growth, slow it down. So it's a completely different mechanism of action. So they will stop BTK, and there's less pressure and resistance, maybe less. I will say that that's a statement that I don't think I can support by any stretch of the imagination. And they are not approved, but are far along in development. And Azumi, can you still hear me? I thought I heard something going on with my earbuds.
I can hear you.
Okay, good. All right, so let's move on to the anti-apoptosis pathway inhibitors. So this is really, so apoptosis is the mechanism of the cancer cells dying. So it's one mechanism of cell death. And we want cancer cells to die. We want good cells to stay alive. Cancer cells can find a way to alter this, this balance of death versus survival by increasing those proteins that are natural in the cancer cells or in any cell, increase those cells that protect against death or inhibitors of death versus the activators of death. So one of those proteins that the cancer cells naturally or commonly, at least B-cell lymphomas, commonly increases called BCL2. It's classically increased in many B-cell malignancies. In fact, in follicular lymphoma, there's a classic translocation involving BCL2 that causes overproduction of the protein, and a way for us to identify the fact that it's actually lymphoma or follicular lymphoma. And CLL is very addicted to BCL2. So if you inhibit these inhibitors of cell death, then you allow the activators of death to kill the cancer cells, to allow apoptosis, a natural process to kill those cancer cells. Again, in this pathway, BCL2 is all the way at the bottom. It's regulated in the cell and the one of the parts of the cell called the mitochondria, but is produced in the cell nucleus. And by this pathway, this B-cell receptor pathway, the same signaling pathway I talked about with BTK, BCL2 gets upregulated by stimulating this process. It does stimulate the nucleus to produce more BCL2. Venetoclax is an inhibitor of BCL2. Again, it inhibits an inhibitor of cell death, thus causing cell death. It works quite well to kill the cancer cells, different than BTK inhibitors, where our goal is to control cancer. With venetoclax, our goal is to kill the cancer cells. And it works, and maybe a little too well, at least initially, because we have to slowly titrate the drug up. And if you start right at the max dose, then too many cells die all at once, and you can cause something called tumor lysis syndrome, which is essentially severe electrolyte disturbances that ultimately can lead to cardiac arrhythmias and even death. So that's something that we did not know about when we first started this, the development of this drug, but it's something that we clearly are aware of now and are very careful for. In fact, when we do Venetoclax, particularly with CLL, we will ramp up over 5 weeks. So you take a low dose for a week, a medium dose for a week, a medium dose for a week, and then the maximum dose by week 5. So you ramp up and you're monitoring for this tumor lysis syndrome as you're doing it. You're drinking plenty of water, which helps flush the kidneys out and keeps the inside. So what ends up happening with tumor lysis syndrome is essentially the inside products of the cancer cells burst, they come out, and then those inside products can get stuck in the kidneys and cause kidney failure. So you're monitoring for kidney failure. You're drinking plenty of fluids to flush out all the electrolytes, flush everything out, so that you can give this carefully. If you do that weekly taper, we've never actually experienced significant tumor lysis syndrome, best I know. So the drug is actually safe. It just is more intensive initially. So Venetoclax comes in a tablet. It's 100 milligram tablets. Although when you're doing this ramp up, there's a starter kit provided, which with each week with the dose of drugs. So there's actually is a 20 and a 50 milligram tablet in these. And then once you get to the 100 milligrams, you just end up taking more of the 100 milligrams. It's best to be taken with food. It's absorbed better with food, has a lot of common side effects, including nausea and vomiting, diarrhea, low blood counts are particularly something we see over time. Fatigue is a common thing. Venetoclax causes a lot of drug-drug interactions. So really, if you're starting this medicine, be sure to tell your doctor of all the medicines you're taking, including supplements, because you may end up if you're not being forthright with some of those things, particularly supplements and over-the-counter medications, you may be getting more Venetoclax than your doctor thinks, and thus the risk of tumor lysis, particularly early on, is a challenge. Venetoclax is approved for CLL. It's also approved for another form of that isn't lymphoma or a B-cell malignancy called acute myeloid leukemia. It's actually more commonly used in these two indications. Although I've used it in multiple different pathways, multiple different other non-Hodgkin's lymphomas off study or off label. So again, Venetoclax causes the cancer cells to die, and thus the goal is really deep remissions, and the lack of what we call minimal residual disease, or looking at the cancers, looking for the cancer cells in a molecular manner, fragments of DNA in the blood, essentially, is common. We can actually get to this really deep absence of any evidence of the disease. It's often given with rituximab or sometimes obinutuzumab. It also allows for a time-limited therapy, so you can stop the medicine. In one particular study, after about 1.5 years off of treatment, 90% of those with undetectable MRD, so deepest level of remission we can identify, remained without progression. So at least 1.5 years, and we're getting more and more data that more and more patients are being able to remain off of therapy. Over time, we don't think this medicine is going to kill any of these cancers, but we do think it's a very good way to control the cancer. All right, I'm going to talk a little bit about PI3 kinase inhibitors, but there's a lot that I had to change with this because of some changes in indication. So PI3 kinase inhibitors, just like the BTK inhibitors, sit right here in the pathway. So this pathway can be inhibited in multiple ways: BTK, PI3 kinase. There are other ways of inhibiting it also. It's active in many forms of cancer, and it's important for cancer survival. It's also important for normal cell survival. There's isoforms, so different types of this protein that can change. one of the mechanisms that PI3 kinase inhibition, one of the mechanisms of resistance is to switch the isoform that's being used. So we mostly worry about delta PI3 kinase inhibitors because they're on blood cells as well as B cells. But there's also gamma, which is on T cells. Beta is on many cells. If inhibiting beta is a little bit challenging. Alpha is on many cells also. It's regularly mutated in solid cancers, and there's particularly breast cancer has some PI3 kinase inhibitors that are approved and work quite well. We can directly target each isoform, although usually when we're targeting alpha, we get a little bit of each one, or if we're targeting delta, we get a little bit of each one. There are currently 3 FDA-approved PI3 kinase inhibitors for B-cell malignancy, idelalisib, duvelisib, and umbralisib. This was last year's slide. I will say now that that is no longer the case. Idelalisib and duvelisib are the only 2 that have an actual indication now. There's also an IV copanlisib, which this is an oral therapy talk, so I'm not going to spend much time on copanlisib. Copanlisib is more of a pan PI3 kinase inhibitor. It does inhibit alpha, which has some effects on the pancreas and the blood cells. There are also many others in development, as well as for solid tumors. So let's go into some of these, some of the specifics. So like the BTK inhibitors, these don't kill the cancer cells, but do stop the growth. Thus, we don't think that they should be stopped. And PI3K is a very important protein on normal cells. So sometimes, particularly the alpha isoform affects blood vessels and insulin. So if you affect this, you may get on-target toxicity, which is hypertension and a transient increase in the blood sugar. These PI3 kinase also somehow causes some degree of immune dysregulation. It does cause a worsening of some autoimmune type reactions, and thus a more mature immune system, which typically happens with initial treatment, really should be avoided. In fact, we don't tend to give these drugs as initial therapy. We tend to give them in later lines, mostly because we see more of this autoimmune-based toxicity. So, like I said, there are 4. This one's IV, so I'm not going to spend that much time on it. Umbralisib was withdrawn. So it was a delta and CK1 epsilon, so a different protein inhibitor. It was an oral drug, took it daily. It was originally approved for marginal zone and follicular, but was recently withdrawn from the market because it did not meet its, when the FDA approves medicines, initially they approve it on emergency or accelerated approval. Umbralisib was approved in that manner, but then when the FDA mandates a more rigorous tests. So usually the accelerated approvals are based on phase 2 studies, low number of patients. With the drug itself did not beat its comparator in its second trial, the bigger comparator trial. Idelalisib and duvelisib, though, are approved. Idelalisib's approved for CLL in the relapse setting. Duvelisib's approved for CLL in the relapse setting also. Idelalisib's delta only. It's a twice daily drug. It comes in tablets, can also be dose reduced to 100 milligrams. Duvelisib inhibits both delta and gamma. It's a twice daily dose, comes in 25 milligrams capsules, and again is only approved for CLL. Copanlisib is only approved for follicular lymphoma. It's a little bit more difficult to give because you have to come into the infusion center weekly for quite a while, whereas these inhibitors are oral and you take them at home. Again, we wouldn't really use these in the frontline setting. We kind of tend to save them for later line settings. More on this table. So idelalisib, we get some of these autoimmune conditions, which include skin reactions, colitis, pneumonitis, hepatitis, neutropenia. With duvelisib, we see some of that, but not as much. Because of that immune dysfunction, immune dysregulation, you do have to monitor for rare infections. So that includes CMV. We prophylax patients for a rare type of lung infection called PJP pneumonia. and then monitor for zoster reactivations or shingles for both of these drugs. Again, I put copanlisib here, causes the high blood pressure and the transient high blood sugar. Can also cause some of the same autoimmune, the pneumonitis and hepatitis. Again, monitoring for rare infections is important. So these drugs are active in many B-cell malignancies. They have toxicities. They can be managed, and some patients tolerate them well. Many newer therapies have replaced, I would say, the PI3 kinase inhibitor class, but the class is still very helpful. And many, again, were approved on an emergency or an accelerated approval, and they are being more carefully reviewed at the FDA. And some of these that are previously approved are becoming at risk for future approvals, and some that were on the market have not made it to the market because the FDA is being very difficult, or I'm sorry, not being very difficult. They're being very careful with this class of medicines because they do have some toxicities that do need to be managed well, and it needs to make sure that they're at least going to be as good as a standard competitor would be. All right, so let's talk a little bit about lenalidomide, which is also another important drug for B-cell malignancies. Lenalidomide works in a completely different manner than any of the other three classes that I mentioned earlier. It has an immune-based reaction, although it does have some microenvironmental effects and does have some actual effects on the cancer cells themselves. But we think the majority of lenalidomide or Revlimid's toxicity or activity is by improving T cell and immune mediated treatment. So it improves the ability of the other part of the immune system to kill the cancer cells. So we often give it with rituximab, which is again a protein that signals that the cancer cells is foreign for these other immune cells to kill. So this is a very complicated, difficult way to really explain, but lenalidomide essentially heightens the cells, the machinery of the normal surveillance of your immune system. And if you give it with Rituxan, which highlights the cancer cells to that immune system, then you can get pretty good synergy. And we've seen that before with a study that randomized patients to get, it's a small number of patients, but randomized patients to just get lenalidomide or lenalidomide plus rituximab. This was in follicular lymphoma, and patients clearly had longer time off of treatment if they got the lenalidomide and rituximab, or longer time to progression. Nowadays we wouldn't give single agent rituximab, and for B-cell malignancies we would always give it with a monoclonal anti-CD20 antibody like rituximab or obinutuzumab. Again, the mechanism of this drug is likely through multiple different pathways. It is approved for mantle cell lymphoma, follicular lymphoma, and marginal zone lymphoma. It is more commonly actually used for multiple myeloma, as well as myelodysplastic syndrome. So if you were looking at this drug and the number of patients who had received it and what their diagnosis were, the vast majority will be myeloma. But it is a very effective drug for mantle cell, follicular, and marginal zone lymphoma. We can give it with CLL, although it does cause what we call a flare, or the lymph nodes actually increase in size, and that can sometimes be difficult for patients. So we don't tend to use it for CLL, but it has been used in the past. There are a lot of ways to give the drug. It has a decent amount of toxicity, so thus there's some dose reductions that have to be managed. Those toxicities can be managed very easily with dose reductions. Typically for lymphoma, we give it 20 to 25 milligrams a day for 3 weeks. And then there's a mandatory off period week. So it's a 28-day cycle. You take it out of 3 out of 4 weeks. We tend to treat for a year when we're giving it with follicular lymphoma. The other ones are a little bit not clear. It's not exactly a good idea to stop lenalidomide for the other medicines. But dose reductions are pretty common for toxicity. One of the interesting things about lenalidomide is that it's actually a derivative of a drug called thalidomide. And thalidomide back in the 50s and 60s was given to pregnant women to help with morning sickness. Unfortunately, it actually caused birth defects. So this is kind of one of those areas of medicine that we all wish we could go back and change. But the FDA quickly took thalidomide, and doctors quickly stopped prescribing it once we realized that. But we knew that thalidomide and its derivatives had a lot of anti-cancer properties. So the FDA started allowing them through a highly regulated program called REMS. And essentially what happens is, and there's multiple other things that happen with this too, but what happens is the patient must actually call in every month and and the physician must send in a new prescription. When the physician sends a new prescription, the patient has to talk to somebody with the specialty pharmacy. This is not a drug that by the way, none of these drugs are drugs that could be received at your local cornerstone or corner store pharmacy. These have to come directly from specialty pharmacies. But anyway, the specialty pharmacy for lenalidomide has to attest that the patient says that they will not get somebody pregnant or will not become pregnant before they deliver the drug to you because of this issue with birth defects, which were quite severe and significant. Again, toxicities are common. There is an increased risk of blood clots, so you must use either a blood thinner or aspirin. Rashes can occur pretty regularly and are responsive to dose reductions. Again, I talked about that tumor flare as the immune cells are going into the cancer cells. Sometimes the tumor, the mass itself looks bigger and feels bigger and gets more painful. So you can get a bit of this flare that happens. And lenalidomide has been associated with second cancers, particularly bone marrow cancers. Low blood counts are the most common toxicity and are managed with dose reduction. If there is some kidney disease, there does need to be some dose reductions. All right, there's one other class of drugs that I'm going to briefly talk about, and then combination therapies, and then we should have plenty of time for some discussion. So Vorinostat, so all of these drugs essentially work on how the DNA itself inside of the nucleus, how much it is available for developing proteins or transcription. So Vorinostat essentially inhibits one of these proteins that works in this manner called histone deacetylase. By inhibiting this histone deacetylase, essentially the DNA is more open, that allows for more of the proteins that will cause apoptosis or tumor suppressor genes, we also like to call them. So they allow more apoptosis, allow more cell killing because they allow the normal machinery to work. And another way that cancer is sneaky is that it prevent some of those proteins from being made. It's a 400 milligram drug. It's taken with food, with capsules. It's FDA approved for cutaneous T-cell lymphoma. So first time I'm talking about T-cell lymphomas today. Adverse events are common, including blood clots, low blood counts, nausea and vomiting, high blood sugar. Another drug that works similar to this mechanism, but in a different manner, so not histone deacetylase, but it uses EZH2. EZH2 is more active in follicular lymphoma. Again, by allowing active EZH2, the DNA becomes more tight and decreases those tumor suppressor drugs. If you inhibit EZH2, it opens up the DNA and then allows those tumor suppressors or those natural proteins that help kill cancer. It is approved for follicular lymphoma as well as sarcoma, which is a solid tumor completely outside of the blood cancer world. It's given as tablets of 200 milligrams, 800 milligrams twice a day. Some adverse events, fatigue, I think nausea and vomiting are the more common things. Do get some low blood counts. There has been some second malignancies or other forms of cancers described. The last one that I'm going to talk about, specific drug we're going to talk about that's approved, is called selinexor. It's an inhibitor of this protein that allows RNA to come out of the nucleus and into the cytoplasm, where it then is made into proteins. The selinexor inhibits this protein, so it keeps some of these more toxic proteins inside the nucleus and prevents the RNA from getting outside and being transcribed. So thus it just alters the way the cancer cells are operating, and allows more of the oncoproteins to stay in the nucleus. It is approved for diffuse large B-cell lymphoma, but also multiple myeloma. It's given twice a week, day 1 and 3 weekly 60 milligram tablets. There are some tablets that allow for dose reductions. And then it does cause a fair bit of side effects. So it's one of those drugs that we're carefully monitored for. All right, the last thing I'm going to talk about is combination therapy. I really only have one slide on this. This is kind of the new hot topic for lymphomas, particularly CLL and mantle cell lymphoma. And some of the some folks on the call may be participating in some of these clinical studies. So clinical development of these combinations are ongoing. Early results are very promising. And the goal here is to provide deeper remissions, but there's a lot of questions that still remain. So again, I'm not going to talk much about this other than to say that, is it better to combine them together or to use one drug sequentially? And how do I even test that? It takes a very long clinical study. Can they be combined at a dose as the single agents? I would say that we've seen a lot of dose reductions, more than we would seen with just a single drug on the early reports of these studies. And most are comparing the BTK inhibitor and not stopping therapy, but not many clinical studies are actually comparing Venetoclax and Rituxan or Venetoclax, where the goal is to stop. So if you kind of put somebody on a BTK inhibitor indefinitely, but also compare them to patients getting a BTK inhibitor and Venetoclax with an intention to stop treatment, what about just comparing it to Venetoclax? We don't know that some of those studies are ongoing. And can we use MRD to help decide if the therapy should stop? All right, so a bit of a whirlwind, but we will certainly have some time for some discussion. But oral therapies typically are small molecule inhibitors of a protein of some sort. They really have revolutionized our delivery of cancer for multiple patients. Some issues with taking them include insurance approvals, having the right insurance. Although we can often get pharmaceutical support for patients if we are having trouble with high copays or costs. Delivery of the drug. So the drug needs to be delivered usually through a mail order pharmacy or at least a specialty pharmacy. You have to remember to take them. They have some typical side effects. And I think future for oral therapies are really focusing on more selective and less toxic therapies, and then combination therapies, and then with a particular interest to the cost of these drugs.